happening during coffee break. So now it's my great pleasure to introduce Dr. Sharon O'Toole from Trinity St. James Cancer Institute in Trinity College, Dublin, Ireland. So Dr. O'Toole, she has been super essential for this cost action. She helped us connect with so many important people, and she has done a lot of work even when it comes to biobanking. She is in fact the head of working group 2 of the biobanking group. So Sharon, the floor is yours.
Thank you, Jean, and thank you to the organisers. I'm delighted to be here with you today in person, and it's great to meet all the people meeting on Zoom over the last while. Can't see this. I'll wait till the slides are up for you there. So I'm going to talk to you today about the liquid biopsy in rare gynecological cancers, but I'm conscious a lot of people are interested in the patient engagement talk that I gave back in Malta. So I think myself and Jean were talking about organising a workshop maybe on that, just because there's been a lot of interest. Okay, so just the outline of my talk, I'm going to tell you a little bit about what is the liquid biopsy, and I'm sure to this audience I don't need to say that. A little bit about CTCs, circulating tumour cells, and the metastatic cascade, the technologies used, and I'll give you a bit of our experience in terms of the different CTC technologies and optimising a pipeline for isolation of ovarian CTCs. Then I'll touch on circulating tumour DNA, and there isn't a whole lot, I suppose, in terms of the rare gynae cancers, but it is an evolving field. And then I'll mention a little bit about World Go Day, which is happening on Tuesday. So what is in the liquid biopsy? So, I mean, there are many components in the liquid biopsy, and the one we're most interested in, I suppose, is the circulating tumour cells. But there's lots of other, I suppose, blood-based analytes in there, and circulating free DNA, and you'll have heard a lot, I suppose, about ctDNA in the last number of years. The circulating tumour cells represent intact, viable, living tumour cells that can be purified from the blood. But also there's exosomes and other extracellular vesicles that can be released from tumour cells. So the metastatic cascade, literally when we're talking about CTCs, we talk about, those tumours that enter into the circulation from the primary tumour and then colonise and set up at a metastatic site. And it's like searching for a needle in a haystack because, amongst the billions of blood cells that are in there, it's very hard to pick out these circulating tumour cells. So I suppose when we talk about liquid biopsy versus tissue biopsy, what are the advantages and maybe disadvantages of looking at the liquid biopsy? And really, we see them, I suppose, as being used together and used as a companion to the tissue biopsy. And the advantages, I suppose, with the liquid biopsy is that it's minimally invasive, a shorter time, highly sensitive, lower cost of sample isolation. But however, it's not clinically validated in a lot of scenarios just yet. It doesn't provide the histological evaluation, but it can monitor continuous tumour evolution and real-time monitoring of tumour response. And you can also look at spatial and tumour heterogeneity. So it does have advantages, but whether at the moment it's more as a companion to tissue biopsy. And I suppose when a tumour cell does enter the circulation, there are lots of blood components that it can interact with. And I'll tell you a little bit about our experience, I suppose, in the work we've done in relation to platelets and the role of circulating tumour cells and the interaction with platelets. But there's lots of components that the tumour cell can interact with: macrophages, T cells, neutrophils. There's been a lot of work recently as well in terms of neutrophils, and they act very similar to the platelets in some of the work that we have done. So just, I suppose, in terms of the platelets, we know that the platelets can cloak the tumour cells, and this can prove difficult, I suppose, when we're trying to isolate these cells and when you're relying on markers that the tumour cell might express, that if they're cloaked with platelets, that can often mask, some of these markers that we use to pull out the tumour cells. And we know when these platelets cloak the tumour cells that it gives it a pro-survival signal. And we have looked across a number of cell lines, and we've looked at a number of markers and to see what's involved in that platelet cloaking phenomenon. But what we do know is it drives EMT, it drives invasion, and it also aids immune evasion. So we know that the platelets are giving a pro-survival signal to the tumour cells and helping them survive in the circulation. And this is seen also in animal models where you have platelet-depleted animal models. You don't see the same metastasis build-up as you would in a platelet-efficient animal model. Just in terms of the technologies that are out there for isolating CTCs, there is the cell search device, which is FDA approved. But I suppose they're based on different properties of the tumour cells, and some of the technologies can be based on positive selection, where you would pull out maybe an EpCAM positive cell or an epithelial positive cell. You have other technologies that are based on negative selection, where they try and get rid of all the blood cells so that you can focus then on the tumour cells.
There's some.
Is that okay? And then you also have ones that are based on density gradient, centrifugation, microfiltration, electrophoresis. So there's lots of technologies out there, and I'll just give you a bit of experience, I suppose, with the technologies that we have used. As I said, the cell search is the FDA approved device, and it has limitations as well, and it relies on EpCAM or pancytokeratin for isolation of the cells. And I suppose a lot of work that we've done, particularly in ovarian cancer, we found that the circulation tumour cells don't express EpCAM very highly, and whether that's because they're masked with platelets or other blood components is something that we're looking at the moment. As well as that, you know, the cell search doesn't give you those viable cells for some downstream applications. We worked initially with the screen cell technology, which is a simple filtration device, and we did a lot of work up in this, I suppose, to make it suitable to the pipelines that we wanted to look at. And, you know, we combined, I suppose, the filtration with a morphological analysis of the circulation tumour cells with a fluorescent image as well. And I'll show you in the next slide, actually. You know, so we developed a pipeline where we took the isolated cells, which are captured on these filters, and we were able to subject them then to downstream immunofluorescence staining to prove that they were circulating tumour cells. And we've done a lot of work in ovarian cancer, and I suppose some of the initial work, we weren't seeing a whole lot of cells in the peripheral samples. So we worked with our clinical colleagues to get some samples from the ovarian vein during surgery, and we found a lot of CTCs were present in the ovarian vein samples. And one of the things we wanted to, I suppose, look at is, you know, what is giving the survival advantage then to the tumour cells that remain in the circulation, as opposed to those ones that are coming out of the pelvic vein of the patient. We see lots of different types of tumour cells. You see them as singlets, you can see them as doublets, or you can see them as these clusters, as you can see here in the slide. And these are quite common in the ovarian vein samples, and also in some of the work we've done on breast cancer, but we do see them also in some of our ovarian cancer patients. And this is the screen cell platform. So this is the filter on the left-hand side here, and you can see, you know, it looks quite messy, but when you zoom in on these cells, you can see that they can be stained for a morphological marker. Sorry, I've just accidentally gone. And then you can stain for an epithelial marker, pancytokeratin or EpCAM, and you can also include other tumour markers, like HER3 is one of the markers we have used for optimization work. And then you can prove, I suppose, that they're not blood cells by using your CD45 discriminator. We moved then, I suppose, we've had this device, the Angle Parasortix device. We had it on loan for a number of months, and it's actually proved quite useful in terms of the ovarian cancer, because I think one of our limitations with using EpCAM was that we weren't picking up all of the circulation tumour cells. So this marker it doesn't rely on, or this device doesn't rely on any particular marker. So it's a microfluidic based technology, captures crunches the CTCs from whole blood based on size, deformability, filtration, and it's independent, I suppose, of the EPCAM. And this device has just received, I suppose, FDA approval purely for the enrichment of CTCs. So it doesn't have that downstream approval yet, like the Cell Search has, but it's kind of the first step, towards the enrichment, and then the cells can be used for downstream technologies. And our current work, as I said, we're doing some work in high-grade serous ovarian cancer. I know that's not a rare gynae cancer, but we have to try and optimize our markers first in terms of the more common cancers. And we also have a breast cancer project ongoing. And we've compared in the breast cancer, we have compared the Parasortix with the gold standard Cell Search, and we've worked with Caroline Dives' group in the UK to do that. And we got very good correlation between the two different platforms. So I suppose it gives us confidence that we don't have a Cell Search system in Ireland yet, so that's why we have to send them abroad for the analysis. But it gives us confidence that the Parasortix device is giving us quite similar results to the FDA-approved device. This is just some of the examples that we see. Again, the clusters of cells, and we believe, I suppose, that, and it has been shown in some papers, that the presence of these clusters is, it's an independent prognostic indicator. So if patients have these clusters present in the circulation, it's not good news. This is just, I don't know if this video will work now, but it's just a video doing some 3D analysis of some of those clusters, and just showing the red there is the blood cells, and the green is the cluster of tumour cells. This one is one from a breast cancer patient, but it just nicely displays, I suppose, the presence of these clusters. So in terms of the ovarian work, what we're doing, I suppose, is looking to see if we can get any clinical applications of the presence of CTCs in the ovarian tumours. And we have been looking at a cohort of patients before they begin neoadjuvant chemotherapy, and then when they come to their surgery, their interval site reduction surgery. And we're not seeing, I suppose, huge differences at the moment, but a lot of our ovarian patients at the moment, and we think it's probably after COVID, they're not reaching that surgery stage, unfortunately, because they have really bad disease. So we're seeing that, we were going to correlate our markers with the chemo response score, but unfortunately a lot of these women aren't getting to surgery, and this is in the last year really we're seeing that a lot, because they're presenting with really bad disease. So this is ongoing work, and we're also staining these cells for the platelet marker, to see if we can find any correlation between the number of platelet cloaked circulating tumour cells that are in the blood, and to see whether that impacts on outcome. So now we do see, when we do this in breast cancer, the number of CTCs does correlate directly with overall survival in those patients. So because, I suppose, ovarian cancer, the markers aren't quite optimized yet, and EPCAM isn't as good a marker as it is in the breast cancer patients. So we are looking at trying to optimize some other markers. We're looking at the folate receptor, we're looking at Vimentin, so that's ongoing work at the moment. And also, as I said, we focus this really on the high-grade serous, but we want to expand to all of the other ovarian subtypes as well, and the rarer subtypes. But it's to get those markers correct, and whether mesenchymal markers or a combination of epithelial and mesenchymal markers will be most appropriate for the ovarian cancer. Again, as I said, the ovarian vein yields quite big clusters of cells, and we're trying to optimize a platform, I suppose, for trying to culture some of these cells, because we've found that the presence of clusters really helps with the culturing. They're very difficult to culture, but if a sample has clusters present, it is easier to culture those, and also we're trying to, I suppose, optimize platforms for single cell sequencing of these cells. And this just shows here, we had used another device, the ClearBridge device. However, you know, all the technologies have their own limitations, and the ClearBridge got rid of clusters, so it wasn't able to process clusters. It's able to process single cells. But because we're particularly interested in the clusters, we are looking for a device that we can pick out those clusters with and compare the single cells and the clusters to see what markers of expression are there in those cells. In terms, I'll just move slightly now, I suppose, to looking at, I suppose, ctDNA, or the broader picture of the liquid biopsy in ovarian cancer. And apologies that I'm not covering all of the other gynae cancers, but I suppose ovarian cancer is one of our main interests when it comes to the circulating tumour cells. But the utility of the liquid biopsy, it has utility in early diagnosis, and there's a lot of work going on looking at methylation status of ctDNA as an early diagnosis marker in gynae cancers. As I said, the CT enumeration, which is part of what we're doing, to try and detect earlier stage disease. But also, I suppose, where it's been used mostly is in predicting response to treatment, and to see, can it guide, I suppose, response to PARP inhibitors, monitoring the response of treatment, detecting recurrence, and there's a lot of work being done in ctDNA across tumour types, you know, as a marker of minimal residual disease. So, and this is something we're interested also in terms of the ovarian vein samples. Does the presence of more cells in that ovarian vein sample tell us anything about the pattern of recurrence in that patient? So we're following up those patients to see what their clinical outcome will be, and so it's ongoing work. In terms of, I suppose, ctDNA and some of the other cancer types, and particularly clear cell, it's a lot of ctDNA work that has been done in the rarer gynae cancers as opposed to CTC work. But there are studies, and particularly, and I know Professor Reid mentioned the Rango study, and they are collecting, as part of that Rango biobank or bioresource, they are collecting samples for CTC analysis also. And I suppose the difficulty with the CTC analysis is that you need to process the sample really within 3 days, you know. So they're taking those samples in special preserve tubes so that they can do that. So it'll be interesting to see what results come out of that Rango study, because they will have a lot of, you know, the rarer cancers represented in that. So I suppose, what do we do with all of the information? And, you know, there's lots of information that comes from the liquid biopsy, and, you know, can it help with that personalised medicine? And we do hope, you know, if we can get down to single cell level, looking at these cells and looking for targeted treatments, I think, you know, we will see changes. The technology is moving, and so hopefully we will be able to do that. And we have a new project starting in Ireland now, which it's kind of the All-Ireland Liquid Biopsy Consortium, which we're part of, and we're doing the CTC arm of that. But it's looking at the different components of the liquid biopsy together, because we've done CTCs, but we haven't done exosomes and other materials. Now, we do have material banked, so we're hoping our retrospective bank can be used as part of the study as well. But in our prospective element, we will be looking at the various components of ctDNA, CTCs, and exosomes. And we have bioinformaticians involved in that project who will take all of the data and try to develop algorithms for prognostic indications. Now, briefly, I'll just talk a little bit about World Go Day. And you heard Professor Reid talking earlier about ESGO Engage and giving a presentation to them. And our groups in Ireland are part of ESGO Engage as well. And I would encourage people to get involved if they are working with patient advocacy groups, because it comes under the umbrella of the European Society for Gynae Oncology. But there's a lot of tools and resources and information sharing within that group. And they have an annual meeting which they give a grant for people to attend if they're working with patient groups. But it's very educational. You get updates from the experts like Professor Reid, you know, and it's usually a 2 to 3 day meeting with a social program attached, and but very beneficial. And I suppose that this group started the World Gynae Oncology Day back in 2019. There's also a day for World Ovarian Cancer, which is longer established, but the World Go Day was really to kind of give a voice to all gynae cancers cancers. So, and they also have a teenager group, you know, so, and they're encouraging if the teenage representatives from across Europe, or that they have representatives in the US as well. And that's really focusing on, I suppose, education of the HPV vaccination for the teenage groups to get that information disseminated within their networks. And that's been quite successful, and so we'll see. That's a more recent venture, I suppose, by the ESGO Engage group. So we work with them, I suppose, as part of the World Go Day. And as I said, it represents the 5 gynae cancers, and the colour purple is associated with it. And we know, I suppose, over 1.3 million women worldwide were diagnosed with gynae cancers in 2020. So the majority of those being cervical cancer, and I suppose a lot from the poorer nations. In Ireland, we have over 2,000 cases of gynecological cancers across the island of Ireland. But for us, I suppose ovarian cancer is the one with the highest mortality, and we've put a lot of focus, I suppose, on the ovarian cancer and getting the message out about symptom awareness. This year, we're doing a dip our dance because the focus this year from ESGO Engage is to focus on uterine cancer and to highlight, as well as highlighting the signs and symptoms, but to highlight the link with obesity and reducing your risk of uterine cancer by increasing, I suppose, your physical activity. So we've developed this dip our dance campaign, and the dance has been sent to Jean. I don't know if she'll manage to get some groups to do it, but we've had a professional dancer choreograph a piece for it, and we have over 30 swims happening across the country on Tuesday. And we have, which is one of the reasons I have to go back, because one of our national news presenters is going to join one of the swims on Tuesday morning. So it's all about, I suppose, you know, this is a way to kind of get it into the media, get it across social media as well, and increase the awareness of all the gynecological cancers. We use this little diagram, which was adapted from the Centre for Disease Control, but it nicely kind of presents, I suppose, the symptoms of the 5 gynecological cancers. The other thing we do in Ireland is we get the buildings to light up in the colour, be it purple for World Go Day or teal for World Ovarian Cancer Day. And that again represents, you know, you have people across the country going to the different buildings and taking a picture, and it's just a nice visual for social media, and it's something that's easily done. So I'll finish with that, just to acknowledge, I suppose, our group, and particularly Mark Ward, who has all those lovely diagrams and figures from the circulation tumour cells. So I just want to acknowledge him and sharing his slides with me for today, and just all of our funding agencies. And again, just to say thank you for the invitation here today.
Thank you very much, Dr. O'Toole. Always very fascinating. Do we have any questions? Yes, please. So just get the microphone.
Hello. Hello to all. I'm Professor Aleš Mandić from Serbia, Oncology Institute of Vojvodina. Thank you for a very interesting presentation. I'm not familiar with that because I'm a clinician, you know. But concerning the ovarian cancer, and we know that the most clinical sites could be getting the ascites. Can we use ascites, because there are lots of tumor cells in it, for this technique, maybe?
And very good question. I think it needs a bit of optimization, because we have tried putting it through our device and it blocks everything. And I think because there's so much more in the ascites, I think it needs an upstream enrichment step that will just kind of to pick out the tumor cells, because there's so much more, and you have pieces of tissue and everything in the ascites. It was blocking all of these devices on us, so we haven't quite worked how to do that properly. But I think definitely some enrichment or getting rid of some of those tissue pieces that are in filtration would help. But it is something that we are looking at. Yeah.
Any other questions? Yes, there is Professor Rasali. Yes.
Not a question really, but as the 20th of September is World Gynecologic Oncology Day, I would suggest, if the ladies agree, to wear something purple, so even just a small thing, to wear purple and to be in the spirit of the day, maybe.
Yeah, absolutely. I brought my purple top for tomorrow.
Yeah. It's a great idea, Clayton. Yes, certainly.
Yeah.
Well, even the gentleman could wear something purple.
Absolutely, yes.
Thank you. Any other questions? Don't see any questions in the chat either. So thank you
Okay,
very
thank
much.
you.
Thank you so much.
No problem.
And we move now to our next distinguished speaker, who is Dr. Jamagata. So Dr. Jamagata, as I said before, she is the brain behind Rare Care Net. We had already the pleasure of hearing her speak during the Malta conference, and she's here again to enlighten us more. So Professor Gatta, she comes from the Istituto Nazionale di Tumori of Milan, and she's going to speak to us about surveillance in gynecocancers. So the floor is to you.
Thank you, Jean, for the invitation. Thank you to all of you for inviting me in Skopje, and I'm very happy to be here. My first time here. I'm not professor, I'm medical doctor, and I started to work in epidemiology at the epidemiology unit in Istituto Nazionale di Tumori Milano many years ago, at the end of the 70s, last century. And I started 10 years after my thesis to work in a big project called Gynocare. The presentation is, I would like to come to start with the presentation, which is, no? Can you help me?
Yes, yes, yes. So let's go here.
Thank you. Okay, this project that was funded twice from the European Commission centralized many cancer register population-based to study survival in Europe for patients with cancers. So we can study more precisely the quality of this data, and we also centralized the analysis. So we could show cancer survival in different countries in a comparable way. So with this big project, we decided that probably to study rare cancer could be a good idea, because study rare events in a big European population could give you very stable and solid numbers in terms of incidence and in terms of outcome. And also we could provide the prevalence of patients with rare cancers. That means how many patients are living with a diagnosis of rare cancers or cancers or another disease now. Well, so a big project, as I told you. The majority of European countries have a national registration, other like Spain and France and Italy, a partial registration, but all of these registries are population-based, that can describe well the situation in the population cohort. But I would like to show you with my presentation also a number of figures that are freely accessible and that come from the IARC Cancer Today, or the website for access to number of cases about incidence and prevalence, the Eurocare, as I told you, and the two rare cancers projects that was funded by the European Commission, the public health program. As many of you showed before, rare cancer pose many questions, like the problem that they are inadequately diagnosed and treated, because it's not easy to find a good treatment because the disease is rare, because the lack of clinical expertise, and also we did not have an idea of the burden of rare cancers. And this is a public health priority, because to have a good number for planning the treatment and diagnosis of this group of patients is important, and you need to know the numbers. So these are the two projects, and from these two projects we could study in depth some important points. With the first project, we understand that it was necessary to provide a definition of rare cancers, therefore to provide a list of cancers. With these two more important information, it was possible to estimate the burden of rare cancer in Europe. It was also important to understand the quality of the data in cancer registration for rare cancer. It's not easy as common cancer, so the diagnoses are not very, sometimes good. And the last aims was to develop strategies for the diffusion of the information that we collect with the project. So the action was to provide the figures of the frequency of rare tumors, incidence and prevalence, and the outcome survival. And to analyze the data quality of cancer registries, and to provide a website where it is possible to find this information. When we started to understand how to define rare cancers, we had a broad consultation process with the experts. Most of them were from the faculty of the ESMO. And the group included clinicians, epidemiologists, pathologists, geneticists, and representative of the Association of Patients. And they decided that we have to provide a clinical definition of cancer entity. Usually we can see a statistic based on cancer sites, no? Incidence of brain cancer, colon, rectal, and so on, but not a more specific definition. So we understand that it is necessary to merge the two information, the topography and the morphology, based on the International Classification for Oncology, the ICDO, and also based on the WHO Blue Books about the specific group, family of tumors. And then another point that we discussed in this broad consensus was to understand which threshold, which cutoff to define the rarity. But this cutoff based on incidence or prevalence. These are two different indicators. The task force for rare diseases decided to base the definition of rare diseases on prevalence. But I was personally against to the use of this indicator, because cancer is a disease with one point, so it's important to understand the diagnosis, one diagnosis, the treatment, the primary treatment one time during the story of the disease. So incidence, that means the new diagnosis in a defined period in a population is better than prevalence. Prevalence is based on incidence and survival. It depends on how long it survives. And using prevalence, for instance, for cancers, you will find lung cancer as rare, because the survival is very short. So probably is not the case. So the board decided that incidence was better than prevalence. This was the most important classification that we used for the list of rare that we provide in several publications, and that was followed by many continents in the world. And because this is the only possibility to define. And maybe it's not as accurate as the professor that was speaking before, but this is the only possibility, and we can ask to modify. Modification is very long, but at the end we can have. Which is important is to know how many cancers are diagnosed as rare. The rarity affects the possibility to carry out effective research. This was the question that the board have to face. Is clinical decision making more difficult if I saw one or another cancers? I don't know if it's rare or not, because at the beginning it was like that. At the end, after a very long discussion, we decided for a threshold of an incidence lower than 6 on 100,000 per year. You know that the list, or you don't know, that the list is available on the web. Sorry. Okay, but we have a doubt in the period of the definition of. We thought that maybe 6 is a very large, is an overestimation of the rare cancers. Better could be an incidence, a threshold of lower than 3. So if we use the incidence lower, the threshold lower than 3 per 100, we reject this list of cancers. The group of experts decided that these cancers probably need to be defined also as rare, because they pose a problem in the definition of diagnosis, in treatment, and so on. So at the end, we were sure that 6 is better than 3. At the first analysis, we compare common with rare tumors, and we, for instance, if we compare the two groups of cancers by age, we can see that incidence of rare cancers is higher with respect to common in the youngest group of patients with respect to the oldest. So incidence is lower in rare cancers in the oldest group with respect to the common, because more cancer are non-epithelial and are more frequent in young patients. Another important observation was that the survival for rare cancer was lower, 5-year survival was lower for rare cancer patients than common. And the difference increased with the increasing of age. And about the number of new cases per year across the countries that contributed the data to this project, you can see that considering all rare cancers, we have very low number in Ireland and with respect to Germany, France, and Italy, where the population is more higher. And for more rare tumors, this number is very, very low, and this poses a question of the organization of the treatment and the diagnosis. Probably is better the network across Europe or across a group of regional European. So the first project on from rare care put a number to a problem low known to exist, show low outcome of rare cancers, made prevalence available for rare cancer because we provided this information, and we were able also to give this information to the task force, and the public health plan. Is important to know how many are living with a diagnosis of rare tumors. And it so identified a new priority for population-based cancer registries. So population-based cancer registries are now able to probably improve the quality of the data. We gave numbers about incidence, about the new diagnosis, about the prevalence, about how large is the population affected by rare cancer in considering all. It was 22%, but increases in the second project to 24%. And that survival is lower in rare cancer patients. The second project, the Rare Care Net, focalized more to the question of centralization of treatment and to update the data, to update the outcome in a more recent period and the frequency of the disease. And we were able to study the trends in incidence and survival, which is important to understand if the outcome improve or not for rare cancer patients. Many associations and societies endorsed the list, and in Europe, the list and the definition of rare cancer. So we were happy about this. This is, again, another table that we can find in the website with the major family, for instance, the neuroendocrine tumors, and the lower subgroup in other group that we consider and for which we define incidence, prevalence, and survival. This is the search tool. You can also analyze the data for all cancers and for all the family, for the head and neck rare epithelial cancer, for the sarcomas, for the embryonal cancer. So you have, for all this group, more specific information on incidence and survival. After these two projects, the European Commission recognized the results of the rare cancers projects and decided to promote the joint action of rare cancers. And this was important for us. So recognize the results and decided to launch the JARC in order to provide more recommendation for national cancer control plans, to include rare cancers in the national cancer control plans, in order to revise the appropriateness of the definition of rare cancer. So we have to, again, have another board of experts in order to understand if the definition was good or not, and then to help the European network of cancer, the network of the EURECAN, the network of for rare cancers. Now there are two networks European. One for solid cancer, EURECAN, and the other for pediatric cancer, PEDCAN. So I think this is important in order to not only to treat patients coming from very small countries, but also to study, to have clinical trial, to have more clinical studies Okay, but if I ask to the IARC, to the website, the Globocan, about two important rare cancers, we define rare cancer, the ovarian cancers and the cervix cancer is rare if analyzed in Europe, but probably is not rare in other countries. So the definition considers the European populations. And so if you consider the word, you may see that cervical uteri, the cancer of corpus uteri and cervix, are two cancers among the most common. And if we consider the European populations, also ovary is included. Disappear cervical cancer, and corpus uteri is also among the most common. If we consider the differences in incidence for cervical cancer, for cervix uteri cancers, you can see that this tumor is not so rare in some countries. So the blue bar is incidence, and then the red bar is mortality. And this graph is ordered from the most frequent to the less. So many countries like Montenegro, Romania, Serbia, Lithuania, the Baltic countries, the Eastern European countries have a very high incidence of cervical cancer. Mortality, the red bar, is not correlated with the incidence. Why? Because survival is vary a lot across countries. That was the major results of the Eurocare. When we analyzed survival, we realized, and it was very impressive for us, to know how large is the variation in 5-year survival among countries. And which is the trend in cervix uteri, for instance. I selected the country with the highest incidence, and you can see that the situation is unclear, because in some countries like Sweden, incidence is decreasing and now increasing. This was the case for other, but it seems that the situation is not good. In some countries there is an increase, in others there is a stable, but just in Slovakia. And in Lithuania and in Bulgaria, where the incidence rates are very high, seem to decrease a little bit. And why about the ovarian cancer? In the 20 highest incidence rates, again, there are a lot of countries with high incidence, and probably in this country, ovarian cancer is not so rare. And again, you may see that mortality vary, but not so much as for cervical cancer. Again, survival different across countries, 5-year survival. And about the trends of incidence for ovarian cancer, again, it seems that there was an increment of the risk, and then stabilization and stable, with some exception of the UK and the Belarus. Okay, now we go to the rare tumors, which you can assess by the search tool of RareCareNet. And you may see that here, incidence is very low for the rare epithelial tumor of corpus uteri, cervix uteri, adenocarcinoma, and so. The most frequent tumor are the epithelial tumor of cervix uteri and the adenocarcinoma of ovary. We study trends of these rare tumors, and we observed, and you can see in the RareCareNet search tool, that there was an increment of incidence in rare epithelial tumor of corpus uteri, but a decrease in epithelial tumor of cervix uteri, in adenocarcinoma of ovary, and in non-epithelial tumor of ovary. So we study a small period, not long as I showed to you before, no? From 1995 to 2007. So this was the results. And again, there are some important description that are these common with common cancer. So the incidence increased by age, and there is no differences just for two types of rare tumors of cervical tumor, but for instance, for the epithelial tumor of ovarian cancers, there is a very big difference in by age. And what about survival? We gave these numbers. Of course, there is a big variation across the rare tumors of gynecological tumors, and the trophoblastic tumor of placenta was very, very good and quite close to 100 after 5 years, and also the non-epithelial tumor of ovary and the epithelial tumor of cervix uteri. But more fatal are the rare epithelial tumor of corpus uteri and the epithelial tumor of ovary, and also the soft tissue sarcoma of uterus. Again, which is the survival, the outcome for cervix and corpus uterus? It's the same important differences, but the situation is very good, is better for cervix uteri than corpus uteris across the different type of rare tumors. For the ovarian cancer, again, there is a good prognosis for the embryonal tumors, and not for the Mullerian mixed tumor of ovary and primary peritoneal serous or papillary carcinoma of ovary. These are the entity that we can define according to the classification, not more definition. And again, these graphs show you that survival, 5-year survival, decrease with increasing of age. This is across age class. There is an improvement of outcome for survival for the epithelial tumor of cervix uteri and for the epithelial tumor of vulva and vagina. And this is the situation, the updated, we can provide, but not publish, yet publish the data because of the GDPR regulation legislation. So for the question of privacy, we have a lot of problem in the centralization and the use of data. I was able to analyze before the publication the data for cervix and corpus uteri for these very rare entities. So I think that we can say that there is an improvement in outcome for ovarian cancers, the different type of ovarian cancers, for cervix uteri. And again, for rare ovarian cancer, these are the the prognosis, very good for the non-epithelial tumor of ovary with respect to the epithelial. And for the other rare gynecological cancers, for vulva vagina, the prognosis is not good, 45%. It was very good for the patient disease of vulva vagina. Fatal for Mullerian mixed tumor of vulva vagina, good for choriocarcinoma of the placenta, and not good for soft tissue sarcoma of uterus. This is just to say that we also for rare tumors, we observed a very large differences in 5-year survival across 4 European regions. We compared the Northern Europe with the UK, the Central Europe, the Southern Europe, and the Eastern of Europe. The same pattern for we observe for rare is for common cancer. These tables, these horrible tables, just to say that for a rare tumor of like the soft tissue sarcoma, there are very few number of cases in the small country like Estonia, the Baltic one, and you have to face about the number, which means also the ability to have a good diagnosis for these tumors. And I also said to you that we studied the centralization of treatment, for instance, in this case for soft tissue sarcoma, in 7 different countries or regions. And we, as you may see, for instance, for Belgium, there is one hospital that treats in a year quite 100 cases. But the treatment of this type of tumor is spread across many types of hospitals. So when we report these results to the country, we had a meeting in Belgium, Bulgaria, Slovenia, they realized they were aware about the low centralization of treatment for this cancer. They were already working on improving the situation. So this is a good example on how to understand. You have now the basis. We start with this situation. We can now analyze the situation after 10, 20 years and understand if the centralization improve or not, and if the survival improve or not for rare cancers. And this is another table to say that, for instance, for the head and neck cancer in Belgium, 25% of patients were treated in 29 hospitals. Or for in other countries like Slovenia, just in two hospitals. So there is a big difference, and even if the population is different, because in Slovenia there is a law. And we also understand that for gynecological rare tumors, there is a large dispersion of the treatment and diagnosis. And this is why we found, for instance, for the ovarian cancer, a large number of morphology unknown in the diagnosis, especially in the elderly. Okay, I'm sorry because I don't know if I take a lot of time. These are my contacts, and please ask for information if you need, and thank you for your attention.
Very, very interesting, and you can see years and years of patient work, and very meticulous. So thank you very much, Dr. Gatta.
Thank you.
Are there any questions for Dr. Gatta? No, I think it's been very, very clear. Thank you.
Grazie. Thank you.
So we move on to the next distinguished guest. So we've got Professor Riccardo Autuzio, who is a professor of surgery, but just to highlight some of the many achievements of Professor Abruzio. He was the past president for the International Society of Geriatric Oncology. He was also the past president of the British Association of Surgical Oncology, and also of the European Society of Surgical Oncology. These are just a few of the highlights of Professor Abruzio. So thank you very much for joining our cross-section, and the floor is yours.
Thank you all for inviting me, for your kind invitation, and for giving me the opportunity to share my thoughts and some concerns, and maybe some controversial topics as well. I notice we are only the first levels, so if you want to throw me out of the window and you might find my statements too shocking, I hope I will survive. Now, how do we, I think this is it. No? They want to do some magic there. In the meanwhile, I reassure you that there is no conflict of interest. And what else can I say? Here we got the panel of experts. I shall disappear.
Extend?
Не, duplicate. Okay.
Asta mă extend pe duplicate, frate.
Értek, keep changes. Ama de duplicate.
Да.
Anyway, I want to congratulate the audience for staying alive after so many hours of interesting discussion. And so from knowledge and to clinical practice. Because one thing that we are addicted is to improving our knowledge, passing it on, but we also want to bring it into clinical practice. We want our knowledge to make an impact on what we're doing. And one statement I want to start from is that whatever the specialty we are involved with in our clinical, in our medical profession, in our taking care for the health of our patients, is the idea that we want patients well. We want to make sure that we do the best that we can for our patients to make them good, not just surviving 1 day or 10 days longer, not just getting more medication, but making sure that the patient quality of life is at the center of our aims, of our targets. Are we able to achieve this? I'm not sure. I'm not sure even we have this in mind when we make attempts to draw clinical investigation to test new medications, new treatment options. I'm not sure we are always trying our best, and I reiterate the fact that the healthcare should be patient-centered. Do we know what really matters to our patients? So I came across this interesting piece of literature that you might like to nip in, and it comes from the MD Anderson. The story goes that they were the breast unit, that MD Anderson had an old and obsolete IT system when they used to run clinics, enter data. So what they did, they say, why don't we sit together with IT people, with patients, with specialists, and everybody says what he has to say, but we ask what is important for our patients so that we can track of it. So they came out with 3 tiers. Tier 1 is health status, survival, and disease control. That is usual, how long am I going to live? How long will I be without disease? Will I be able to go back to functional status and go back to work. This is what first one level matters for our patients. And then the process of recovery was also interesting. I don't want my treatment to be delayed. I don't want to be discontinued in the treatment. I don't have reoperation, readmissions. This I really would like not to have. And then the third level is cosmetic outcomes, physical well-being. Am I able to go back to the society to bring my grandchildren to school? So these are things that we never take care of when we are practicing when we are sitting in our clinic, but we should, because this is what matters our patients. So this is not just an inspirational talk for surgeons, but it's meant to be for all specialties. Indeed, surgery is an ongoing creative process. We keep learning from mistakes. We make constant reshaping and changes, whether we are improving or not. In view of what I just said, is still debatable, but this is our aim. One question back is, are we able to assess the true value of a surgical? Is this a good procedure or is it a bad one? Do we know how to assess this one? So I want to bring you an interesting example. If you take a rectal cancer, we used to treat it in a standard way, and we had a local recurrence of 1 in 4. And now it's less than 10%. Almost 1 in 2 patients had distant metastases, and now it's 1/5 of the patients. The overall survival has moved from 45 to 67, 70%. And the local recurrence was 1 in 3, now is 1 in 20 or 1 in 30. Why is that? This is for the introduction of total mesorectal excision. What happened there is that this chap here, Bill Hild, he produced, he thought of inventing, creating a new technique, and he tested it, and he retrieved this data, and then people started following him, and he managed traveling. So he went to the Netherlands, he went to Scandinavian countries, Norway, Denmark, and this is a paper which is a population-based investigation where in 10 years, the whole country, actually the whole countries have shifted completely their results because of the introduction of this technique. Now, I'm saying this because I'm questioning these statements by which someone is adamant, and here is example of Prof. Alderson in the UK, that whatever we do should be evidence-based according to clinical trials. I have a little problem with that. If you consider that clinical trials only include young patients, elderly are excluded. They should be fit and the frail we don't want to include. Patients with no medication, polypharmacy excluded. Literal patient, well-nourished patient, wealthy patients, affluent, and self-sufficient patients. And if on the top of that you consider that those patients, those trials who ended up with negative outcomes are not going to be published. So when you draft your level 5 evidence-based piece of science, the meta-analysis, you obviously forget about the negative trials. Here it's absolutely obvious that there is a little problem here. And on the cherry on the top of the cake is the sponsorization, that sponsorship bias in clinical research is obviously there. So I'm arguing the gospel of the RCTs, and I'm actually advocating a special interest on level 4 population-based, good quality clinical investigation. I'm particularly vulnerable on this statement because I well know that surgical trials are very difficult to set in place. First of all, the procedure is not standardized. Simply to say, the way you throw a knot is different from the way I throw it myself. My fingers are longer, I'm left-handed, and so on. The surgical control and the credentialing is different. The working team as a whole is different because you are a very good surgeon, but your anesthetist is a miserable chap. So your outcomes are going to be much worse than mine. And my intensive care, my theater nurse and circulating nurse are different. So it's not the surgical act which can be randomized. It's the whole unit performance. And also we should never forget that 1 in 5 surgical recruited patients into surgical trials are discontinued. Finally, this is very important, in surgery we have no sponsorship. So there is no medication to deliver. You change your glove, so you a different piece of string, but it's not enough to sponsor a clinical trial. Is this very bad? Well, look at the example of keyhole surgery. Keyholes, laparoscopic surgery. This was introduced by a gynecologist, by the way, in the 80s. And it took only a few months before it started going into amelioration. It kept improving. The camera was changed, the sticks were improved, the tools, baskets to retrieve organs, little tricks, working with the team, the anesthesiologist, patient had to be tilted, now it's no more. The technique has constantly evolved dramatically. So we would have lost 30 years if we had to design a trial, set it in place, complete, analyze the outcome, and prove that, surprise, surprise, laparoscopic surgery is quite good. And that's why 97% of modern surgical procedure is performed through keyhole surgery. So it is my understanding that RCTs are not necessarily in the best patient interest as a whole. On the other hand, I want to warn you warmly that there are numerous examples of medication and surgical procedure, intervention and treatment options which are totally out of the blue. They are never demonstrated, never tested. We have a list of them on the market. They are severely introduced and pushed by the industry that patients want them. They demand them. They ask for it, and they're not keen to come to me unless I have this special technique. And because of that, the end result is that politicians are asked to fund hospitals to make the magic instrument available. That's how you want robotic surgery. There is no whatsoever evidence that cancer surgery is better dealt through the robotic magic expensive machinery, but everybody wants it. You don't want to go to any surgeon who is not on the list of robotic surgeons. And this is because we are constantly pushed dramatically by the big pharma and the greedy of this approach. If I have a few minutes more, I want to expand on this and just say that in 2016, Barack Obama allocated $215 million in the budget for precision medicine, which was it was discussed at the State of the Union in 2015. The spending was projected, as you can see, quite a substantial spending, and here is how costs are allocated. I want you to have a look at the novel approaches, the yellow bar, which is substantially getting more and more expensive. In other words, new medications like nivolumab, ipilimumab, they cost quite a lot and they are substantially more expensive than gold. And I wonder whether you might have thought that this is an insane way to move forward, considering that since in 2015 there were 8 main drugs, new novel oncological medication approved for an annual cost of $100,000 per patient and a gain in survival of 2.2 months. And here is the representation. So I think that the way we allocate money is really a little bit awkward and should be reconsidered. I would like to draw your attention toward the best patient care. I would like to make sure that from now on we retrieve more patient-centered information. But I also want to remind you that the target is to work together with patients, with the industry, because we don't want to fight the industry. We need the industry and their improvement, but we want to make sure that we are on the right track to collect data, good quality data. And this is really my main interest. I think that with the advent of artificial intelligence, which I do not understand as a super robot who is doing my job, but I want artificial intelligence to assist me in the automation, in the learning skills, information, technology, artificial neural networks, big data analysis. I want the artificial intelligence in healthcare now. I want to assist me in collecting good quality data everywhere so that we can share the data, compare the data, and make progress. Of course, I cannot avoid touching on digital dictatorship, which is totally outside my speech, but it's a big, scary issue, and some of you might be well knowledgeable. So I'm saying all this to you because I firmly believe that the Gynocare, that your project is interested in basic research, in biobanking, in regulatory requirements for international research, and that's a unique opportunity to expand knowledge, to share with the community and bring this knowledge into practice. From my point of view, because I'm editor of a journal which is the European Journal of Surgical Oncology, where by coincidence a couple of years ago we had a special issue dedicated to rare cancer and edited by Gemma Gatta and Sergio Sandrucci. And here is a list of the topic on tumors that they discussed. Of course, I think that you have the opportunity to identify team leaders, compile a list of topics, assign topics to different experts, retrieve the epidemiological data, and make sure that this information is matching with the clinical impact, not just it's a mathematical information, it's a numerical information that we don't really know how to bring into clinical practice. So I would like this to be sent into press, and I'd like this to become your Gynocare business or business card for your success in the future meeting. Yes, we have an above 5 impact factor. We receive over 2,000 manuscripts per year. Of course, more here on the right, golden access papers are more frequently visited, and unfortunately we have a very, 80% rejection rate, because if you want to excel, you can only accept good papers. The manuscripts are revolved quite promptly. basically developing research, producing original information with a clinical impact, disseminating knowledge and impacting on clinical practice is extremely interesting. I thank you for your attention.
Professor, this was a really, really interesting talk. Are there any questions from the audience? Yes.
Thank you very much for this lecture. You get the point. You get the point, because I think nowadays with all these trials and everything, that's a close field. Although patients are very filtered. But today, I just want to know. Is there any change, because all these trials and results, we are going to make a huge gap between the implementation of the results in standard, normal, daily practice. Because lots of our patients will never get these results or these drugs, whatever. Just look the previous presentation about the cervical cancer, for instance. The high incidence, high mortality rates in countries where all these results that we get for the treatment, target treatment, immunotherapy, will not be able to give to our patients. So we get in the frustration of doctors, because I know what is the good for the patients, but our health systems in these countries cannot follow all these expensive things. Also, we are trying to do so much looking for the result. You see, you mentioned that surgery trials. I totally agree with you. For instance, minimal surgery for the cervical cancer, just one trial, leg trial, just abounded and ascended another standard of care not to do minimal surgery for the cervical cancer. And everybody goes to robotic, and everybody goes to the laparoscopy to do the cervical cancer, and now one trial and just made chaos. And then some other clinicians who just pushed the minimal surgery using robotic surgery. In Serbia, for instance, there is no robotic at all. Only one. You know, so, and it is very interesting for us what we, with all these trials, results, and everything, what can we offer to our patients in daily clinical practice? Or is just our playground for the academic people to do to see. Look at the liquid based. Maybe one center, two centers, very good results and everything. For instance, in Serbia we can't get it because it's too expensive. You know, I think that these all nowadays results of these are too expensive for the bringing to the, because the health system in these countries are affected with the high incidence of all cancers cannot appreciate all these things. We're still on the playground. I'm looking as a clinicians to get these drugs, whatever implementation in a daily clinical practice. It is not that lady will be lucky if you go in trial. If it's not, I just look at her and gave the only previous drugs or whatever. So health system have to follow these results of the trial.
I think it's a very good point, and I mean, what you said, Professor, reflects many countries. I mean, not just the Eastern European countries, but even small countries with, especially if it is, whatever type of health system, whether it's public, whether it's private, so maybe your thoughts on this.
Well, law and middle income countries, I'm thinking Africa, I'm thinking of really financially vulnerable countries, they are totally out of the equation. But if you look at the opposite, US affluent countries, financial toxicity is a common condition. Financial toxicity is people selling their house, losing the job, losing everything because they are under the impression that the $200,000 per year to treat granny is going to change, and it's not going to change their life. And so your point is well taken, I agree with you, but if you look at it from a different angle, this is all good stuff for pharma company. And we need to decide who are we, which is the perspective that we are using. I think it's our responsibility to look at the patient's interest. I feel passionately about wearing the trousers of the patient and giving him or her what is good for them. And that's why I advocate retrieving more information on patients' outcome, quality of life, financial issues, financial data, and using more of what you are retrieving international, what Gemma has been using. So if what the total mesorectal excision or experiences are really able to achieve without the need of a trial. Thank you.
I think this is very interesting. And there's one more question, and then after this one question, we can continue networking during lunch, but we'll take the last question. Thank you.
Good morning. Just a following up question, like about the main topic, but why just like are the surgical options are still not that like getting more advocated? Is that surgeons are spending more hours in surgery rather than like emergency rooms or something like this? So that's maybe also always a lack of reporting of the surgical results. As a following question, is there like any movement of standardization of like surgical interventions to like have more valuable or reliable results to be presented as an alternative for the very expensive surgical? So
yeah, I hope that we are looking into these and we are getting better and better. I dispute the need to get into the minor details, i.e. is it better using the right hand or the left hand to perform a sentinel node biopsy. I think it's important to know whether sentinel node needs to be taken out in an elderly breast cancer patient, for example, that we don't know. And still we don't have data, clear data on prostatectomy versus radiotherapy versus hormonal treatment. I don't think we have conclusive hard data. And this is all a matter of having good population-based data rather than getting into the detail of the surgical technique. So hopefully we will be getting there. And with your help, of course, because this is in your hands.
I just want to comment because in my starting presentation, actually, it was I said it like that. Surgery is still not obsolete. It can still be a good chance of survival in the next 50 years. And standardization, and as you said, this guy and dissemination of that information. We have been in medical congress in Plovdiv in Bulgaria last week, and actually mesenterium is considered to be an organ, a separate organ. Probably it will be like that if it's not already considered. And these advances in surgery are always important. But I think that what is more important is that actually projects like Gynocare actually confront all of us, but including the pharmacy sector. I don't know how far we have reached to the pharmacy sector, that one, let's say, diagnostic genetic test, which will bring the company $500 million, but the cytostatics will bring her $5 billion, so that we have to convince them that they will lose 4.5 billion, and that's good. But I'm not sure if we can convince them that. So that's the problem we have with the pharmacy and with the research, actually.
Yeah, a
So
give
that's
and
something
take,
very
yeah.
important.
Yeah,
And thank
you're
you for
right.
your presentation.
Thank
It
you.
was fantastic.
Grazie.
Yes, we do have a working group which is linking pharma. That's working. Oh, sorry. Yes, we do have a working group, which is working group 4. Yes, I'll stand there. Yes. Okay. So thank you again, Professor Abduzio, and we do take your offer on the special issue. We'll talk more about that later on today also when we have the MC meeting. It's definitely an honor to have a special issue in your journal. So yes, we do have working group 4, which is the bridging the gap with pharma, and working group 5, which is the ultimately bringing together to go for clinical trials which are really benefiting the patients. But what I would suggest at this point is that we break off for lunch. So lunch is outside, and then I mean, I am aware that we're a little bit late, but maybe instead of meeting at 2:30, we could meet at 2:45, if there's time, yes? That would give us like 3/4 of an hour, during which not only would you eat, but you can also network and, make new friendships and contacts. So thank you very much. Thank you to all. Thank you. Thank you. Okay.